So we start to talk about observational studies. There are two different types of observational study: descriptive studies that just describe frequency, natural history, and determinants of a condition. And then we have analytic studies that describe association between exposure and outcome. Here on the right, you can see the observational studies in which the investigation doesn't decide which patients will keep the investigation drug, let's say, and which ones no. On the left, we have the randomized clinical trials. Alexander will talk about this later. There are three different types of analytical studies. We have cohort studies in which the investigation proceeds from exposure to outcome, case control studies in which the investigation proceeds from the outcome to the exposure, and we have cross-sectional studies in which the study proceeds independently from the follow-up. We will explain this. This is the pyramid of the evidence, and as you can see, as long as you proceed from observational study to randomized clinical trials to meta-analysis, the degree of the level of evidence increases. So these are the important keywords for observational studies that really describe the nature of this study design. These studies are non-interventional. They are not controlled, meaning like there is a lot of space for confounders, for example, or we don't know if we are comparing two groups, one using one drug and another one not using the drug. We don't really know if patients are really taking those drugs. And then we will describe the different design. We will kind of prospective or retrospective study design. So what does it mean that observational studies are non-interventional? It means that the investigational medicinal products are authorized, so we are not testing new treatments. It means that investigational medicinal products are used in accordance with the terms of the marketing authorization of the member state concerned. The assignment of subject to a particular therapeutic strategy does not depend from a study protocol, but from the clinical practice in the country in which the study is performed. And diagnostic or monitoring procedure, in addition to normal clinical practice, are not applied to the subjects who are involved in an observational study. So the design can be prospective, that it means that if the study starts today in 2017, we will look for outcomes in the next years, in the next months, in the next years. It can be retrospective, that it means that if the study starts today in the 2017, we will see if outcome happened in the past. And it can be a we can have a cross-sectional design, that it means that we don't consider at all the follow-up, but the study exists only in one time point. I will come back to this. Exactly. So in a cross-sectional study, the study exists only in one time point. It means that in this point, we consider the study population and we check how many patients have the disease of interest and which ones have not the disease of interest. And then we check how many patients in each group had a risk factor present or absent. And then we compare, I don't know, for example, the proportions. So we don't consider at all the length of the follow-up. We don't have a follow-up for this study design. There are some merits and some limitations for cross-sectional designs, and the merits are that these studies are quick, cheap, allows to study several disease and exposure at the same time. They are very good to assess the prevalence of a disease, and they are really good for public health planning. And the limitations of these kind of studies are the temporal ambiguity, because we just consider the study in one time point, so we don't know what happens in the future or what happened in the past. So maybe if we just move the study 1 month later, we will have different proportions and different results. There could be possible measurement error. They are not suitable for rare conditions, and there could be survival bias. Then we have case control study design. In this kind of study, if we consider that the study starts here in 2017, we studied the baseline characteristics of our study population, and we can determine which ones are the cases and which ones are the control, meaning which ones have the disease and which ones don't have the disease. And then we look in the past how many patients had the factor present or absent according this disease or no disease, and then we compare the proportions. There are, the assumption of this kind of study is that known cases are representative of the source population of cases. And merits are that they are suitable to investigate rare disease and outcomes, and they can be not really expensive. Limitations are that they are not suitable for calculating frequency measures, not appropriate for rare exposure, and there could be selection and recall bias. Then we talk about core studies that can be prospective and retrospective. This is an example of a prospective study. We check baseline characteristics of the population today, for example, in 2017. We evaluate our population, and we divide the population in two groups according if patients have or do not have a particular risk factor. And then we have a follow-up, and we check in the future if patients will develop or not the disease, and we'll compare the risk. The same type of study can be also retrospective, and it means that if the study begins here in 2017, we go to check, for example, in 2000, the baseline characteristics of the population, and we check in 2000 which patients had or did not have a risk factor present, and then we look in 2017 which patients developed or did not develop the disease. So these kind of studies have as merits and limitations. The merits are that there is a temporary relationship between exposure and outcome, and this did not happen, for example, for cross-sectional studies. They allow to investigate several outcomes for each exposure. It is possible to perform matching, limiting confounding role. They are easier and cheaper than a randomized clinical trial. They are good to measure incidence of an outcome. The limitations are they are more expensive as compared with case control and cross-sectional studies, but of course less expensive than a randomized control clinical trial. The outcome could take time to occur. The definition of outcome exposure can change over the time. There is no randomization, so there is a lot of space for confounding. And there is the blinding and masking could be an issue. So now we talk about registry. Registry studies are nothing more than cohort studies. So we need to define registry. Registry is an organized system that uses observational study methods to collect uniform data, clinical or other, to evaluate specified outcomes for a population defined by a particular disease, condition, or exposure. There is no restriction in time or type of collected data, so really few inclusion and exclusion criteria. In principle, there is no testing of research hypotheses. There are two types of registries: product registries that include all the subjects that are receiving a drug of interest, and then there are disease registry that include all the patients who have one specific disease. For example, an example of the first type of registry could be, for example, a registry of NOAC, of novel oral anticoagulant. An example for the second type could be, for example, an heart failure registry, including all the patients with heart failure in a country, for example. So the key words for this type of studies are like core studies. They are not interventional. This emphasizes that treatments are not decided by healthcare providers and patients and not by protocol. Cohort studies, this is an epidemiological term to define a group of subjects with something in common who are followed up over time. And we talk, when we talk about this type of studies, we talk about real-world data, somehow to distinguish this kind of study from randomized clinical trial, and just to point it out that these kind of studies have really fewer inclusion and exclusion criteria as compared with the randomized clinical trials, and this means that maybe data coming from these kind of studies could be more representative of what really happens in the daily clinical practice and in the real world. So these are the basic rules for data collection in a registry. Data are collected in a naturalistic manner. The registry is designed to fulfill a specific purpose, being defined before collecting the data. The registry captures information with specific and consistent a priori clinical definitions. So it means that we need to define the variables before starting to collect the data. Otherwise, we will have hypertensive patients, for example, defined in different ways according to the center who collected the data, for example. So the data are collected in a uniform manner for every patient. The data collected reflect the clinical status of the patient. So we will have data about the history of the patients. Then we will have data about examination, laboratory tests, and patients reported data, for example, how they feel, and so on. Registries include the type of data the clinician would use for diagnosis and management of patients, and this is different, for example, as compared with trials. So registries are really important for post-marketing surveillance, and they are very good to evaluate short, long-term effectiveness of drugs. They are good to measure the safety and tolerability of drugs in the long term, and they are very good to measure and or improve the quality of care. So this is an example of registry. I provide this because I work on this. This is Riksvik, that's the Swedish heart failure registry. This is a quality care registry. It means that it was founded for improving the care in heart failure in Sweden, and it can be also used for research purposes. So it's a nationwide continuous health quality and research registry. It was founded in 2000, and at the moment we have around 70,000 patients. The coverage is 60% in Sweden. Actually, there is just one inclusion criteria for this registry. That's clinician-judged heart failure in inpatients or outpatients. And we just exclude patients from pediatric departments and the patients who decide to opt out from the registry. It means that if a patient goes to an hospital in Sweden, an hospital that's covered by the Swedish Heart Failure Registry, all the patients are automatically included in the registry, but patients are informed about this and they can decide not to be included. So it's the other way around as compared with many other studies in which the patient has to sign a consent to go in. So we collect around 100 baseline variables for the patients who enter the Swedish Heart Failure Registry. We collect this on a paper CRF and then it's transferred to an online CRF. And we have actually outcomes that are not collected by the investigators, but they are automatically collected, matching the Swedish Heart Failure Registry with the population registry. This means that the country of Sweden knows when a Swedish resident is dying, and they collect this data. And so if we have patients in the Swedish heart failure and we want to know if some of them have died or not, we just match the Swedish Heart Failure Registry with the population registry, and we will know information about if these patients are still alive or they died. There are no missing data for outcomes, and of course, patients who move out from Sweden are censored because we will not have information about the outcome anymore. So we matched the Swedish heart failure registry also with other registries. So I was talking about the population registry for the outcomes, but we also match it with the causes of death registry. That's a registry that collects all the causes of death in Sweden. So we will know if patients with heart failure have death because of cardiovascular disease or any other kind of disease. We can match our registry with socio-economic registries, so we can know how much our patients earn, level of education, socio-economic conditions, how many children they have, if they are married or they live with someone else, or if they are single, something like that. And we can match our registry, again, with the National Patient Registry, and we can know more information about comorbidities that are collected by ICD codes in a hospital. We can also match our registry with other cores, so we can have controls for heart failure patients. So we can have a registry including patients with and without heart failure, actually. This is an example of our CRF, and this is just to show you how many variables we have: age, gender. We know if they are inpatients or outpatients. We know in which kind of departments they were actually registered. We know when they were registered. We know if they are smokers or not. We know ejection fraction. We know NIA class. We know blood pressure. We know the reason of the heart failure. We know all the cardiovascular, not cardiovascular comorbidities. We know all the treatments that they are receiving, because we can match our registry also with the dispensary drug registry in Sweden. That means that all the Swedish residents who go to the pharmacy are registered, so we can know what they took from the pharmacy, so we can know which drugs they are receiving. So this is an incredible source of data. And this is the stroke statement. And so if you want to perform a registry-based study, this kind of flowcharts help you to understand which factors should be described in your paper. And I just want to provide an example of a new type of study design. That's a registry-based randomized clinical trial. We are performing this in Sweden, but also in US, based in Sweden at least on the Swedish Heart Failure Registry. You know that the Top Cut study raised more questions than answer to the questions. So actually, by this, we want to investigate if spironolactone is working in patients with HFpEF. And it's impossible to do another clinical trial on that because we already had the Top Cut. So we are testing this in the Swedish heart failure in Sweden, based on Swedish heart failure registry data, but using a randomized fashion. So it means that we collect using Swedish Heart Failure Registry, we can check in Sweden which patients satisfy the inclusion criteria to enter our study. So they have HFpEF, they have NT-proBNP higher than thought, and they have specific conditions. And if patients are not included in the Swedish Heart Failure Registry, but they are seen in our departments, they satisfy the inclusion criteria of our study, they are included in the Swedish Heart Failure Registry. Then patients are randomized in spironolactone yes or spironolactone no. So it works like in randomized clinical trials. And in the follow-up, actually, we just have 4 visits, so at 1 week, 1 month, 6 months, and 12 months, in which we perform, for example, potassium and, creatine measurements, this kind of lab measurements, and then for the follow-up to know if the patients had or not the event, and in our case the primary outcome of the study is cardiovascular death, we just match the Swedish heart failure registry with the national patient registry, and we see if patients had or not the outcome. This means one thing, that this kind of trial is extremely less expensive as compared with a traditional randomized clinical trial. And in this very nice slide, in a review that we did in Stockholm, we compared the three different study design. I mean, randomized clinical trial, registry-based randomized clinical trial and registry. And we see that in randomized clinical trial, there is a big advantage, that's the randomization of patients, but there are a lot of disadvantages that are actually, they are really expensive, a lot of inclusion and exclusion criteria, they may not be representative of real-world patients. For registries, we have a lot of advantages, so they are cheaper, and we have a lot of information of the patients, etc., but there is no randomization. So it means that we cannot really test a drug because there is a lot of space for confounders. But with randomized, with the registry-based randomized clinical trials, actually, we can find a compromise between these two study designs. So we can have a randomized clinical trial that is cheaper than a traditional randomized clinical trial, and it includes a lot of benefits coming from the registry. And so I think this could be a study design really more used in the future. And so this deserves to be actually discussed. So this is an important guide if you want to learn more about registries. And with this, I thank you for your attention. If you have any questions, you are welcome, actually.